pretty long lecture, so I'm going to jump in and say a few words about the quiz, and otherwise we're just going to jump into the lecture. Everybody did, the class as a whole did great on the quiz. So I was really, again, thank you all so much for studying so hard. And even if you're somebody who's not entirely pleased with your individual score, overall, I think everybody's doing great. If you have questions about the quiz, just come see me about your individual quiz. Please come see me during one of the breaks, and I'm happy to discuss it with you. Okay. I'm only going to talk about one thing from the quiz, which, to my surprise, was the most missed rhythm on the whole quiz. And I was like, what? Because nobody had any trouble with this with this group of rhythms during class. So I think I know why people didn't do well, but on this, and I would say about a third of the class. I mean, most people got it, but a big group got it. So what is it, Grace?
It's wandering atrial pacemaker.
Okay. Now, if you missed it, you're in good company because there was a group of you who missed it. And the only thing I can think of, I even went back and I looked at the handout, the paper handout, and said, was it something different there? Because people kept saying it's a normal sinus. And the only thing I can think of, and if you got it wrong, I put the same comment on everybody, is look at all of the P waves. Because this is my speculation, I think the reason that people got it wrong was that the middle group does all look the same. So if you just glance at it, which we all, believe me, all have a tendency to do, glance at it and jump to conclusions. If you do that sometime, you're not alone. There's a big group of us who do that. But you can't do that, especially on an ECG test, okay? And if we're looking for 3 different morphologies, they're actually pretty easy to find. That's what surprised me, is some of the wandering atrial pacemaker we've looked at only has 2 different morphologies, and we have to sort of make a decision about what it is. In this particular case, you can see this is, I think, significantly different from here, and this is significantly different from the rest of it. So we have our 3 different morphologies. In addition, even though we only have 6 seconds here, remember that one of the versions of wandering atrial pacemaker is this one that starts up in the SA node or near the SA node and starts moving down toward the AV node. So in a somewhat regular fashion, the P waves will start getting smaller, and then they'll actually just disappear when the pacemaker goes either into the AV node or very close to the AV node, and then it'll come back up again, which you can kind of see on this. So are there any questions about this? Is there anybody who just has questions about it before we move on? Okay, so in a clinical setting, making the mistake of calling this a normal sinus rhythm would make no difference whatsoever, okay? So there are some mistakes that we make which make huge clinical ramifications. This is not one. The problem is, of course, is you don't know which, especially when you're just starting off, you don't know which one of those mistakes have ramifications, so you want to make as few as possible. But in a testing situation, it does have some ramifications. So I guess the take-home lesson is, we've got the final ahead of us. Be sure to go across the whole 6-second strip before you make your decision, okay? Okay, so today is the last lecture. Next week will just be practice. And we're finishing up with kind of a bang, I think, by doing AV blocks. And I think it's fair to say, I don't want to make you nervous, but I think these are the rhythms, I don't want to say where people struggle the most, although I suppose I could, but have to work hardest to master. Okay, so that's one of the reasons why I put it at the very end. Okay, so first of all, what is an AV block? And Of course, it stands for atrioventricular block, and it has to do with a delay or even, interruption of the transmission of an impulse from the atria to the ventricles, and I'm surprised I didn't put it here, within the AV node. Okay, that should be the end of that sentence. Caused by an impairment of the conduction system within the AV node. Okay, that's why it's called an AV block. So just a brief review. So Spencer, what happens when the impulse reaches the AV node in a regular situation?
There's a slight delay.
Absolutely. So it's delayed. And Riley, how long is a normal PR interval?
I have small X's.
And exactly. And if I said, first of all, that's a correct answer. If I said, what does that translate into seconds? What would you say?
1, 2 to 2. Or
Correct.
1,
Yeah, that's good. That's good. Okay, so again, we've looked at this picture and one like it quite a lot. So as we, this is such old news, the impulse leaves the SA node, goes to the AV node, it pauses, and then it jumps into the ventricles. Now, all AV blocks, and there's a number of them, involve some slowdown or even complete blockage of the impulse at the level of the AV node or just below the AV node in the bundle of His. And if you think of the AV node as a gate from the atria to the ventricle, just think of the gate as working slowly or even shut. But if there is an AV block in the AV node, what's happening in the SA node? Well, the truth is, because it happens below the level of the SA node is probably just doing its job, just throwing out impulses in a regular way. Okay? So an AV block has no effect on what's happening in the SA node. And what I think of with all AV blocks, the SA node continues to fire, creating a regular pattern of sinus P waves. And in a way, I think of that as the key to understanding when you're looking at an ECG strip, the AV blocks, okay? So again, if the blocked AV node, or just below it in the bundle of His, if it's blocked here, that has no effect on the SA node. And the SA node, unless something totally different is happening, but it's, just because of the AV, blocked AV node, the SA node's fine. It's just throwing out its impulses one after another, creating a regular pattern of sinus P waves, okay? Now, there are 4 different types of AV blocks. First degree, second degree type 1, second degree type 2, and third degree. And there are a few little subdivisions or categories within those 4 main categories that we'll discuss. But this is the 4 main types of AV blocks. So when none of the P waves are blocked and they all transmit through eventually, that's going to be a first degree block. When some of the P waves are blocked, that's going to be some form of a second degree AV block. And then when all of the P waves are blocked, it's a third degree AV block. And so that's when we're talking about degrees, you can see, no true blockage first, a little bit of blockage second, completely blocked third. Now you would think that it makes sense to go through and explain each one, doing the first degree, then the second degree, and then the third degree. But that's not how I do it, and I'll tell you why. Today, and we're going to go through all of them today. We're going to review the AV blocks in this order, first degree, then we're going to jump to third degree, then we're going to come back and do the second degree AV blocks. And the reason is I've put them in order of difficulty. So first degree, piece of cake. Third degree, pretty simple, and then it starts getting a little gnarly with the second degree AV blocks. So we're going to kind of build up to it. Now, first degree blocks are truly easy, okay? A first degree AV block, if you have a sinus rhythm with a first degree AV block, it looks just like a sinus rhythm, except that the PR interval is wider than 5 small boxes. Looking at the ECG strip, that's the only difference. The only difference from a normal sinus or sinus Brady or sinus tach, and the same thing with a first degree AV block, is that impulse just for whatever reason sits in the AV node a little bit longer than normal. All of the impulses get through. When you're looking at a first degree AV block, there is 1 P wave for every QRS, 1 QRS for every P. There are no orphan or non-conducted P waves, unless something else is happening. So here's the first degree AV block. The rhythm is regular, the rate is whatever it is, and the PRI is greater than 0.2 seconds. So you can see it's just a normal sinus rhythm with an elongated PR interval. And in this particular example, they're showing it as 0.26. That's just a possibility. It could be 0.3, it could be 0.4, it could, it could be anything. It just has to be longer than 0.2. So here's our little summary. First degree AV block, again, the only thing different on this summary from a normal sinus rhythm is this. So the rhythm is regular, both the P to Ps and the R to Rs. The rate varies, meaning that it can be slow, it can be fast. You can have a sinus Brady with a first degree AV block, you can have a sinus tach with a first degree AV block. But the important thing, and you'll see why it's important when we start talking about the other AV blocks, is that the atrial and the ventricular rates are exactly the same, because the ventricular rate is still being controlled by what's happening in the sinus node, because every impulse gets through. The P waves are upright sinus P waves, 1 P for each QRS, 1 QRS for each P. PR interval is, and unless there's an IVCD, the QRS is less than 0.12 seconds. So I'll let you read that. The first degree AV block, typically, more likely than not, is that true? Well, at least quite a lot of the times is not an indication of a pathological something. In fact, there are a lot of conditioned athletes who simply have, it's one of those things probably because of, an increased parasympathetic system, have an elongated PR interval. So it doesn't necessarily mean anything bad at all. And again, note that with a first degree AV block, there are no orphan P waves, which will not be the case with any of the other AV blocks. Yeah.
So since the P waves are sinus, these only happen in sinus and atrial rhythms?
All of the AV blocks can only happen with a sinus and atrial rhythm, okay? And you'll see, keep that question in mind, you'll see what I mean, okay? So here are some examples of first degree AV blocks, and I'm going to point it out here, but in a minute you're going to look at your handout and find them for yourself. So you can see that the PR interval is longer than, you can see how it's longer than that one large box. It's quite a bit longer. This one, looks like about 7 small boxes there, and this one, about the same. So I think you can see it. And also, what may not seem all that important now, but will be as we get into the higher degree AV blocks, it's not just that the PR interval is long, but they're consistent all the way through. They're all the same, which we're used to because that's the way it is in a normal sinus rhythm. So now what I want you to do is get out your handout and go to page 27. Let's see. Let's see what it says here. Oh, I don't know if this is the case of mine, it's that page is flipped over. Anyway, 27. And all I want you to do, and you can do it on your own or with your neighbor, your partner, is 37 and 38, but I'm sure you can find it. It says AV block, handout for AV block lectures.
Close
Oh,
that,
okay.
because it's
Sure.
getting me in the eyes.
All I want you to do is go through it on your own for a few minutes, then we'll do it together and say, is this a first degree AV block? Yes or no? That's all you have to do, okay?
Do it myself, so if I do that.
Oh, I see what happened. Okay. Okay. So, Natalie, number 1, please.
I said no AV block.
Yeah, and pretty straightforward. PR interval is normal. What is that, by the way?
Brady?
Yeah, what kind of Brady? Sinus Brady.
Sinus Brady.
Yeah, there's other bradycardic rhythms, which is why I'm asking. Okay. Grace, what about number 2?
I said yes.
Yes, and the way to say this is a normal sinus rhythm with a first degree block, or first degree AV block, or first degree AVB. It's kind of a nice way to do it. Okay, so Koa, what about number 3?
No, it's borderline.
Is it?
Between 3 and 5.
So, actually, you can even see it because here's our large box here, and it goes, you can see it overflows over that large box. But if you want to use your calipers to measure, it's not a hugely long one, but I think it's pretty clearly longer than
Because I
0.2.
use the 5th one where it lines up like directly on it and it looks really good. I also don't have my handout, so I can calibrate it.
Oh, why don't you say something? Let's get back at the end of class. Okay. So, Cody, number 4.
I said no.
Okay, and what is that rhythm, by the way?
The inverted P, so it's a junctional.
Excellent, okay. And then Chris, number 5.
Yes.
Yeah, and again, what's the rhythm? Is it a sinus tach or a normal sinus? 10, 20, 30, 40, 50, 60. It looks like a normal sinus. Yeah, so this would be a normal sinus with a first degree AV block. And then Anne, number 6, please.
No.
Okay. And what's the rhythm?
It's like sinus or sinus Brady with ST.
Yeah, sinus Brady. Okay, and then Spencer, what about number 7?
7 is a sinus bradycardia with AV block.
Oh, what?
AV block?
What is it? Does it have a first degree
Oh, I'm
AV
sorry,
block?
first degree AV block.
That's all we
yeah.
want to know.
Okay, sorry, yes, AV block, first degree.
Okay. Any disagreement? Yes, Grace.
You have orphan P waves.
Yeah, so I've sort of tricked you here, okay? So in fact, I've sort of tried to suck you into saying yes because not your fault, you fell into the trap, is that it's true, it is true that the PR interval is too long, but remember one of the qualities of a first degree AV block is there's 1 P for every QRS and 1 QRS for every P. There are no orphan P waves.
There are orphan P waves present in this one.
Yeah, okay. And so we don't know what this is yet, which is why it was kind of an unfair trick. But I'm not above that at all. And so it is. We don't know what it is, but we do know enough to say it's not a first degree AV block. Okay, Riley, number 8, please.
Spencer, we're talking about this. We're having a little bit of a hard time deciphering, but I said yes. But then he brought up the point that we're not entirely sure that that's not the P wave, but for me it looked like that was the P wave. So
Yeah, you're correct. And here, why don't you point to the P wave?
Sure.
And then we'll talk about how you know. Okay.
These are the P waves.
Excellent, excellent.
So,
And what is the underlying, what is the rhythm there?
looks like sinus tack, maybe IVCD.
Yeah.
Yeah. Maybe not, no.
No, I think you're right. I hadn't noticed it. Okay, so good. Yeah. So it's sinus tachycardia with a kind of a borderline IVCD and a first degree AV block. Now, how do we know that these are not the T waves? Where are the T waves and what's notable about them?
T waves looks like there's significant ST depression. So
Uh-huh.
I would say that the T wave falls within this
Yeah,
depression here.
so exactly. So there's ST depression with an inverted T.
Mhm.
So you wouldn't have any trouble with this. It's just that P wave, because it's a sinus tack, the P wave has backed up and it's almost falling into that T wave. So good job. Okay, and then Koa, you're the last one there, number 9.
And,
Yeah, correct. So we can see little tiny p's, but the PR intervals are normal. Okay, we're done with first degree AV block. We'll come back and practice it and so forth, but that's all we have to say about it. So we're going to move on to third degree AV block. Okay, so third degree AV block, one of the things that makes it relatively easy, I think, is conceptually, I don't think it's very hard to understand. So third degree AV block is complete heart block, okay? There no longer is any way for the atria, for the impulse from the SA node to get down into the ventricles. It just, every single impulse that tries to get down, it's like it's been cut. Okay, or the bridge has been dynamited, or whatever particular metaphor you want to use. Okay, complete heart block. Okay, heart block, third degree. The impulses from the atria fail, from the SA through the atria fail to get through. Complete heart block. Okay, now what do you think happens if if there's no communication between the atria and the ventricles? What do the ventricles do?
Just chill.
If they do too much chilling, it's going to be like arrest. So what do the ventricles do?
Become the ectoplasm focus.
Yeah, so remember, that's what those escape rhythms are all about. It's not as though the ventricles say, well, that's it. I'm not doing anything. The ventricles jump in and start pacing themselves, okay? And we're going to expand on that idea with a little more specificity in a few minutes. Now, third degree potentially is the most dangerous of all the AV blocks because if something happens to the ventricles, then you're really screwed. Okay, so with the third degree AV block, the atria, like all AV blocks, are in a normal sinus rhythm. So with third degree AV block, just like with all AV blocks, you're going to see a regular pattern of P waves across your ECG strip, okay? So, in other words, the atria continue to be paced by the SA node at the intrinsic rate of what? Who remembers? Intrinsic rate of the SA node. 60 to 100, okay? And, as always, take these rates with a grain of salt. Could be a little slower, could be a little faster, but essentially, the atria are just in a plain old normal sinus rhythm. So you just see these P waves marching across. Okay, the ventricles are left on their own, and depending on the location of the AV block, we're going to come back to that in a moment, will be paced by an ectopic focus from either the AV node itself or the ventricles. So let me explain what I mean by that, because that's probably a little confusing. Okay. Here's our heart. SA node, AV node. And I'm going to draw the AV node kind of longer here. Okay, someplace in this vicinity, there's going to be a complete block that's just going to stop all impulses coming from the north, okay, coming from the atrium, okay? If the block is here, the impulses come down, stop there, and now below is the conduction system for the ventricles. That's not said right. Below are just the ventricles, okay? So the only way to pace the ventricles has to be someplace within the ventricles, right? Okay, so nothing is pacing the ventricles because this gets blocked, and maybe an impulse over here says, oh, I'm going to start sending out impulses, so what we're going to have is a ventricular escape rhythm, okay? And it's going to come from here, or maybe it comes from here, or maybe it comes from here, but at any rate, it's from someplace within the ventricles, okay? Does that make sense? Then what you're going to see in this particular third-degree AV block are P waves, sinus P waves, combined in a way that you're going to see pretty soon with a ventricular escape rhythm. Okay? Both of those are going to be present on the ECG strip. Okay? Make sense? Say if it doesn't. Okay. There's another possibility. The block could actually be here, at the top of the AV block. It's still a third-degree AV block. It's still 100% complete block. All the impulses are going to come down and just die right here. But now, there's going to be a part of the AV node that hangs below the block. So now we have two possibilities of where the pacemaker can come from, where the escape rhythm comes from. It can come from within the ventricles, but it can also come from within the AV node itself. So it's possible for the ventricles to be paced by the AV node, and what you'll see on the ECG strip is a junctional escape rhythm. Okay. So we're going to, I think that's not a simple concept. We're going to go through this several times during this lecture. So don't worry about it if you think, I think I have it. Okay? Okay, third degree AV block. Now here's the trick, is there are, if the let me ask a question. If the atria are in a normal sinus rhythm, Chris, I'm going to ask you this question. If the atria are in a normal sinus rhythm and the ventricles are in a ventricular escape rhythm, are there going to be more P's than QRS's, or more QRS's than P's, or exactly the same? What would you expect?
Say that one more time.
Okay, the atria
Yeah.
are in a normal sinus rhythm, P wave, P, 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 all the way across. But because it's blocked, the ventricles are going to be in an escape rhythm. So let's say they're in a ventricular escape rhythm. So you're going to have QRS's. Are there going to be more P's than QRS's, or more QRS's than P's?
More P's than QRS.
Bingo, okay? Because the intrinsic rate of the SA node is faster than a ventricular escape, okay? So you're going to have regular P to P's and regular R to R's, but the atrial and the ventricular rates are different. So even though you're going to be able to march out the P's and then go back and march out the QRS complexes, there will always be more P's than QRS's. The P waves are sinus, because the SA node's doing its job, with no connection between the P's and the QRS's, more P's than QRS's. We'll come back to this in a minute. The QRS is variable in the third degree AV block. Remember all this business here? If the ventricles are doing the pacing, the QRS will be wide. If the AV node is doing the pacing of the ventricles, if there's a junctional escape rhythm, the QRS may be narrow. So again, we're going to keep working on that idea because I think that's a hard one. So both P's and QRS's march out evenly, but at different rates. There's no connection between the two. So let's look at it because it's so much easier to look at a picture. When you look at an ECG strip, and I hope everybody can see, even at a quick glance, you can say, oh, I think there's some orphan P's here, or at least there seem to be more P's than QRS's, okay? So you should start suspecting AV block. The first thing you do is take your calipers and march out this is step one, but it's the part of step one that we've never had to do before. We march out the P's, okay? Take your calipers and march them out. And then march out the QRS complexes. Cody, question?
How do you know that's a
P-wave?
non-conductor PAC?
Great question. Is a non-conductive PAC, what does the P in PAC stand for?
Premature.
Premature. Got it? So that's why we make, to be honest, that's the only reason we make such a fuss about non-conductive PACs, because it's, unless you know what you're doing, you're going to confuse with an AV block. Okay, that's the importance of marching out the P's and seeing that they march out evenly, which will never happen with a non-conductive PAC. Great question. Yes?
Can you have a third degree block with the PAC, non-conductive PAC?
I'm sure it's possible, but I'm not sure I've ever seen one.
Okay. 'Cause
Okay.
when we get to our worksheet, I have a question.
Okay, let me throw in what might be the problem is, remember that the atria are in a normal sinus rhythm, with all the caveats of any other sinus rhythm, meaning that there can be some variation, just like there can be with a normal sinus, so there can be some variation with the P-waves.
Okay.
Okay, but I can see that didn't persuade you, so we'll get to it, to the worksheet. Okay. Okay. Now here's the deal with the third degree AV block, is that remember what's happening is that the atria and the ventricle are doing their own thing. No communication between the two. They're just going, the atria is going P wave, 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 and the ventricles are doing QRS complex, QRS complex, QRS complex. It is possible for them to happen at the same time, okay? Because the P waves are not causing the QRS complexes like they do in a normal sinus rhythm. Yes?
What's going on with the valves when this is happening? Because if they're going to do it,
This is a whole separate deal, because valves have to do with blood and mechanics and so on, and this is the
Right.
one.
Yeah, I was just curious. I mean, if the atria are kind of just, they're firing at
They're
different rates.
probably contracting, but it's not. I see why you're asking. I see why you're asking.
Yeah.
Okay. I honestly don't know. My guess is not. I think probably what's happening is the ventricles are simply responding to the. I think the valves must just be staying closed, but I don't know. That's an excellent question, and you can see I don't know.
No worries.
Okay.
I'll look at it. Thank you.
So, okay, so to find what happens is that sometimes those QRS complexes and the P waves happen at the same time. So it's very common with a third degree AV block to have buried P waves that are distorted or even invisible because of the QRS complexes happening at the same time. So you need to find them, because if you are trying to march them out to see if they happen evenly, you have to be able to find the P waves. So here's how you do it. The first thing you do is you take your calipers and find one obvious P to P interval. Does everybody understand what I mean? There's nothing in between. P, P. Here's our P to P interval, okay? And then go one way. Oh, this little bump on the back of the T wave, it's a P wave. Oh, this weird looking thing here, it's a P wave. And I actually think it's helpful, especially when you're first starting off, or if you have a really gnarly one, is to put little marks saying P, 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 so you know where the P waves are. And then you go the other way with your calipers, and again, you can see, oh, okay, that's a P wave, that's an obvious P wave, here's another P wave, okay? And again, sometimes if they hit at precisely the same time, you won't even see the P at all, okay? So here are the P waves, and again, I think it's helpful to mark the hidden P waves if you're having difficulties. And now we can see Oh yeah, the P to P intervals march out evenly, but we had to find the P's first. Yep.
So on 7, the one you tricked us on, they're all buried into the T's. Is that why the T's so big?
Oh, yes, but that's actually not a third degree. So we'll get to it. We'll get to it, okay? This is a long, exciting, as it unfolds, lecture. Okay, we'll get to it. But that was good. You're absolutely correct on that one. Okay. So again, so here is another third degree AV block. And how do you find these? Well, you take your calipers, find 2 P to P's, and then you can start marching them out. And you can see how they really can get, really buried. So it's helpful, again, to find them. Grace, are you raising your hand?
Yeah,
or-
that's the one. That's the first one.
Okay.
So I didn't know that the P could be buried in the QRS complex.
Uh-huh.
So I was trying to march them out.
Right.
And it didn't line up. So
Yes.
that's the non-conductor.
Yes. So now
So
you're in the know.
Yeah.
Okay. Okay, here is another example. And this one's great because, for at least as an example, because you can see how, again, and we're already used to the idea of P's being buried in T waves, so it's not like that's such a new idea, but you can see how they really will get totally buried. Okay, so on this one, let's see, what do I have you doing? This is, mine got all screwed up. Okay, part 2, third degree. So page 39 through, so 2 pages. And again,
Did you start on this page?
all I want you to do, part 2, third degree AV block, 10 through 17, is it a third degree AV block or not? Okay? And if it's not, if you happen to know what it is, you can say some of these are going to be second degree AV blocks, which we haven't had yet. So in that case, you can simply say it's not a third degree AV block. Before we start, I don't know if everybody read the little thing at the top, but go back and look at it because I know we're going to say it. I'm going to be saying it. So here's the deal with a third degree AV block. First of all, you begin to suspect a third degree when you see orphan P waves, non-conductive P waves. Think, oh, third degree AV block is a possibility. Third degree is the only one of an ECG strip that has orphan P waves where, number 1, the P waves march out evenly. Number 2, the QRS complexes march out evenly. And number 3, the PR intervals are not constant, they vary. Okay, so that's the description. So with that being said, I don't know where we're at. Let's see. Does somebody have a pointer or any? Oh, Riley, but you didn't. I think Cohen, you just went, right? You went?
Chris just went.
Chris just went. Okay, Anna, it's you. Okay. Number 10, please.
Number 10, I would say yes.
Yes, what? Yes, a third degree AV block?
Third degree.
Yeah, and again, if you march out the P waves, finding the buried ones, of course, you'll see the P waves march out evenly, the QRS complexes march out evenly, and the PR intervals, and this is common with a third degree AV block, are all over the map. There's no consistency, there's no pattern, okay? You have a medium-sized one, you have a non-existent one, you have kind of a long one, you have a short one, okay? So there's no consistency in the PR intervals. And of course, we have orphan Ps. Questions? Okay. Spencer, next one, please.
I do not believe that there is a third degree P block.
You're correct. And I know I didn't ask this, but what is this?
It looks like the sinus radiocardia.
It does look, and it is a sinus Brady, but now as part of your repertoire of moves, you're corrected as a sinus Brady. You always have to check the PR intervals from this point onward, because we know that it could also be a sinus Brady with what?
It looks like it might be it is a first degree
Excellent.
block.
Excellent.
It is a
Si-
real-
Sinus
correct.
Brady with first degree AV block. Okay, good job. Okay, Riley, you're number 12.
I'm gonna say no. Initially, I came in thinking that, hey, I see what kind of be orphan P waves, but they're not, and I realized the R-to-R intervals are not, they don't
Even.
march up evenly.
Yeah, they don't march out evenly. And you're done with that, because if all I'm asking you is, is this a third degree AV block? Again, with a third degree AV block that, by the way, did the piece march out evenly?
No, I guess not.
Actually, they do.
Oh, they do?
Yeah, okay. So the P's march out evenly, but as you point out, the QRS complexes, the R-to-R intervals, do not march out evenly. So at that point, can't be third degree, whatever else is happening there, okay? Okay, so questions? Again, we don't know what this one is yet. We haven't had it yet. It's one of the second degrees. But we know it's not, by the way, could it be something with a first degree AV block? We've had that one.
Could it be one? Is it what you're asking?
Yeah.
I don't think, no, I don't think so, because there's, I guess they're orphan P waves. They seem kind of like melded
Yeah,
T
there are
waves.
orphan P waves. So right there, nope, not a first degree AV block. Okay. Okay. Hella, you're next.
Okay, for 13, there are orphan P waves. P waves march out evenly. The QRSs, even though they're wide or they're long, they do march out evenly. I was confused since the PRIs are not varied, but do they all have to be in the
There has to be
criteria?
some variation.
Okay.
And is there,
I don't see variation. when
neither
I'm-
do I.
Okay.
Okay,
it's not-
so we don't know what this is yet because we haven't had it yet. It's one of the second degree AV blocks, but we know it's not a third degree AV block because it fits all the criteria. Coa did this perfectly. It fits all the criteria except, the PR intervals are very constant. So it cannot be a third degree AV block. Okay? Andrew, do you want to skip till you feel
I'll
like
give
you're
it a
comfortable?
go,
Okay,
the one I just heard.
okay,
14,
yep,
so I think it is a third degree,
okay.
just because the PRI varies and everything else is regular.
Did you march out the P waves?
Yeah,
Okay,
and there are.
yeah, and found the
even-
buried ones and everything?
Yeah,
Yeah, okay, yeah, perfect. So the P waves are constant, the QRS complexes are constant, there are some orphan Ps, and the PR intervals vary. Third degree AV block, nice job. Okay, number 15.
I don't think this is a third degree because the PRIs intervals are good.
Yeah, they are good. It's probably the only good thing on this, right? So, do the Ps march out evenly?
Yes.
And the QRS complexes march out evenly?
Yes.
And are there orphan P waves? Yeah, but again, the PR intervals are constant. Okay.
For 15, would you also, is that also an IBCD? Or
Um,
is it just because it's the third, or it's not a third degree?
it's because of what it is.
Okay.
So, yeah. So, okay, number 16, please.
I said yes, it's third degree.
Okay,
The R to R is equal, the P to P is equal, and PRIs are different, and it's orphan P.
correct. Okay, question? Okay. And then finally, number 17, Cody, please.
So the QRSs march out to be the same, the PRIs are variable, and they're orphan Ps, so unless they.
And did the P to Ps march out evenly?
Yes, they do.
Okay, perfect.
So
So,
this is the third degree.
yes. Okay, good job. Riley, question?
I just wanted to go back to 15, and I guess
Okay.
13. What made that a no was you were saying we decided that the PRI is within parameters, which is why it's.
But I don't like the term within parameters because I don't know what you mean. What do you mean by within
I
parameters?
guess I don't know what word to use. So you said they were. I didn't hear what you guys said when you were talking about it. It's kind of why I'm asking. I'm not
Okay,
sure.
so the PR intervals, just to be clear, the reason I don't like within parameters, I don't know if you mean long, short, or whatever.
Right.
They could be long, they could be short, that's not relevant here.
Okay.
It's whether they're constant or not, whether they're the same all the way
It's
across.
the same with each.
Yeah, so if you take your calipers, you'll say, here's our PR interval.
Yeah.
It's precisely the same as this one, it's
Oh,
precisely the same as that one. Now, it doesn't matter in the context of AV blocks. This could be in this context of third degree, or this is going to end up being second degree. It could be a wide PR interval. What we're looking for here, that's not what we're looking for. We're looking, are they the same as the other ones on the strip?
It's a constant, you said.
Yeah, it's constant. It doesn't vary. Okay.
Thank you.
And same thing with 13. It was exactly the same issue.
Thank you.
Okay, questions? Okay. Now, I'm going to go through this one more time just because it's sort of important, and I think it's a hard concept. So the ventricles are left on their own depending on the location. The AV block will be paced by an ectopic focus from either the AV node or the ventricles. I don't have to repeat it again. I've already repeated it once. But atria and ventricles are depolarizing in third degree AV block. The atria always are in a sinus rhythm, and there's no association. But again, and this is what I drew over here. If here's the AV node, if the block is at the top of the AV node, then the AV node itself is below the level of the block. And that means the AV node is available to provide the escape rhythm. The pacemaker could be found within the AV node itself. And in that case, what you're going to have is a narrow QRS and probably a little bit faster of a ventricular rate, because what this is a junctional escape rhythm, and everything you know about junctional escape rhythms will apply, meaning it's narrow as long as there's not an IVCD, and the intrinsic rate is 60 to 100. Okay. However, if the block is just below the level of the AV node, now the AV node itself is no longer available to provide the escape rhythm. So the pacemaker can't come from within here because it's above the block. And in this case, the ventricles have to pick up the slack and provide a ventricular escape rhythm. And everything you know about ventricular escape rhythms are going to apply. The QRSs will be wide, and the rate will typically be a bit slower than if the pacemaker is in the junction. Okay? I'm going to skip the next through few slides because I go through it again, and it's a difficult concept, but it's not that difficult. So, okay. Look at the two strips on the following slide. Both show a third degree AV block. And I'll show in a minute. What I want you to know is, based on what you see here, which one is more likely to be paced by within the AV node itself, and which one of the ventricles more likely to be paced by the ventricles. So which one is a junctional escape, which one is a ventricular escape? So whoever thinks they know, just raise your hand. Yeah, Grace.
The bottom one is paced up in the ventricles.
Correct. And then the top one by the junction. And you're exactly right, and for some reason I thought it was clever to switch it and then put it, so that's kind of a dumb idea, but anyway, you're right. So they're both third degree AV blocks, okay? But this one is paced by the junction, this one by the ventricles. Okay. Despite the amount of time I've spent on that concept, I actually don't think it's that important, okay? When you identify a third degree AV block, all you have to do in this class is say third degree AV block. You don't have to say third degree AV block with a junctional escape or with a ventricular escape. Yeah.
Are one of these more common than the other? Like, are we going to see a ton of third degrees but never see firsts?
I think, well, so let me answer it in a couple ways.
Yeah.
Oh, say that, what was your question again? Maybe I misunderstood what you said.
I just want to know if one type of block is more common.
Oh,
than
block, not the, first degree by far.
Really?
Yeah, by far. Because first degrees can happen for benign purposes.
Right.
And also, third degree usually always is some underlying more serious pathology.
Okay.
Yeah.
On the sorry, excuse me. The AV node pacemaker one, I'm struggling finding two clear P waves to start measuring.
Oh, that's a good
Can
question.
you show me?
Yeah, boy, that is a great question. So what I would do here is, you're right. So just to understand what's happening is that usually we can see orphan P waves because the atrial rate usually is so much faster than the ventricular rate that a couple of P waves will happen in between the QRS complexes. So in this particular case, I was specifically looking for a junctional escape that was within a junctional escape rate. And so that's why it's so hard to see it. So I think what I would do on this one is I would try, in fact, I think I would do this one and this one. And the reason I would do it is because it's possible something is buried here, right? But if so, it's not going to march out evenly because this is not in the middle of this. Do you see what I'm saying?
Yeah.
So I would try this and just see if it makes sense. So we go here, we go, oh, here's one. And then this one, oh.
That's where I got confused.
Yeah, so this one, you can see there's a little blip here. And then that one, and then that one, and then again, that's probably this blip here. So that's how I would do it. Yeah.
When we're doing our final answer, do you say the underlying rhythm with third degree block, or do you just say third degree
Okay,
block?
that's a good question. There's two ways to do it, okay? It's kind of the formal way of saying it is sinus rhythm with a third degree AV block, okay? Or sinus Brady with a third degree AV block, okay? That being said, most people simply say, oh, it's a third degree AV block. And I'm okay with either one. So you can say either one. Now, here's where people get tripped up. If you're going to say it's a sinus rhythm with a third degree AV block, okay, and you say a sinus Brady, for example, with a third degree AV block, make sure that the Brady part are the P waves, not the QRS, because what happens all the time is that people say a sinus Brady with a third degree AV block, and in fact the sinus rate is about 60 to 70.
Gotcha.
So the way to skirt that is simply say sinus rhythm and don't worry about whether it's Brady or tachy or whatever
Okay.
with a third degree AV block. Okay? Okay. Third degree AV block is the only rhythm, and then this is just a repeat because this is so useful, where the P, first of all, of course, they're orphan P waves. I don't have that on the slide. P to P's march out, R to R's march out, and the PR intervals vary. There is no connection between the P waves and the QRS complexes, okay? So remember way back when we first started looking at ECGs, we talked about there's one P for every QRS and one QRS for every P, and then, you know, if I'd been sitting in class, I would think, well, duh, that's obvious, isn't it? Up to this point, it has been obvious. This is why we have that in there, is there's no connection. So in this case, there's almost always more P's than QRSs. Okay? Okay. Let's go a little further before we take a break, even though we're moving into difficult territory. Second degree blocks can be a little more bewildering, okay? So we're going to discuss, again, this is one of those ones where you can kind of break it. You have to choose how much are you going to break it down. And my choice is that, first of all, second degree type 1 and second degree type 2 are the main two second degree AV blocks. There is an umbrella term that we are going to learn near the end of the lecture called second degree AV block 2-to-1 conduction. And I will tell you now that this is the umbrella term that we're going to reserve for the occasional time when we can't tell second degree type 1 from second degree type 2. Okay? And we'll come back to that. Now, first of all, one of the confusing things about second degree AV blocks is, like so many things in medicine, there's a whole bunch of terminology. And I honestly don't care which one you use, but you have to understand what other people are talking about, so you need to learn all of the terminology, even if you don't use all the terminology. Second degree type 1 has 3 names, okay? And they all mean the same thing, okay? Second degree type 1, that's very straightforward. Mobitz 1, that's another thing you can call second degree type 1. And my personal fave is Winky-Block. So if you want to say, oh, that's a Winky-Block block, by all means, it's fun, okay? And it's very legit, okay? Second degree type 2, by contrast, is a little more boring because it only has 2 names, second degree type 2 and Mobitz 2. Again, be my guest. Use whichever one feels better in your mouth. It's all good, but you have to understand what other people are saying. Okay, I'm going to explain the underlying mechanism, what is happening in the heart with a second degree type 1 block, AV block, okay? So the AV node, for whatever reason, has a second degree type 1 AV block. And what that means is, again, like all AV blocks, the SA node is just doing its job, throwing out impulses, sinus P waves. An impulse comes down from the SA node, hits the AV node, and just goes right through. Maybe has a normal PRI, just goes through. The next one comes down, hits the AV node, and this time it goes through, but it takes a little bit longer. There's a little bit more of a pause, so the PR interval is a little bit more stretched out. Let's say the third one comes down, and who knows, maybe this one gets through too. But again, it takes a little bit longer. The PR interval is a little bit more stretched out. It's as though you can think of the AV node getting progressively lazier and lazier, okay? And then finally, one of those impulses from the SA node comes down, hits the AV node, and this time it says, forget it, I'm not going to do it. And it doesn't conduct that P wave through. And you're going to see on the ECG a single orphan P wave. Because once it's had that little break, then the next one that comes down just goes right through. And then the next one comes down, goes through, but maybe a little bit longer. And the next one comes down, maybe that's the one that's blocked. Non-conductive P wave, orphan P. And then the next one comes down, goes right through. Okay, so that's the pattern. Okay, let's look at some pictures. So here's the first one. First one just goes right through, and maybe the PR interval is normal. Maybe it's a little long, hard to say. Okay. The next one comes down, and it's slower. It's still going to get through. It's still going to conduct through, but it's slower. So the PR interval gets longer. The next one comes down, and now the block is getting stronger, and the PR interval elongates further. And again, there's no particular reason why it has to be 3 or 4 or 2 or whatever. It just is what it is. But eventually the block gets so strong that it totally blocks that impulse from going through, and you have an orphan P, a non-conductive P. Okay? And then it starts over again. The block sort of disappears, it goes through, the next one it goes slow again. So it's this pattern of progressively longer PR intervals. Again, another picture of it. Okay, each PRI gets progressively longer until there's a single drop. Okay, here's a normal PR interval, a little bit longer. It's taking a little bit longer, and now we have an orphan P. Okay, and one of the characteristics of second degree type 1 is that there's only a single orphan at a time. Because the next one, it's as though the AV node just needs that little bit of rest, and then it goes back to normal. Yeah?
Do the QRSs always march out evenly?
Yes. No, the QRSs never march out evenly, sorry, because there's always this gap. It's kind of like having I hate to say this, but it's like having any kind of pause in the middle, like a sinus block or something like that. So one of the characteristics of second degree type 1, with one exception that I'm not going to talk about quite yet, the QRS complexes never march out even. Okay, so here's our little summary guide. Rhythm, regular P's, irregular QRS complexes. Because remember, when that one gets blocked, you have a kind of a pause in the QRS pattern. The rate is whatever it is. The P waves, again, the P waves march out evenly and they're sinus, and there's always more P's than QRS complexes because we always have that single non-conducted P at the end of our little pattern. PRI is the characteristic, if you will, or one of the defining characteristics of a second degree type 1. It becomes progressively longer. And then, again, there's nothing about this rhythm that would make the QRS wide, so unless there's an IVCD, the QRS will be narrow. Second degree type 1 typically is not a very serious rhythm, okay? Again, this is one of those ones, it's possible you have a perfectly healthy person, you throw it on and there's a second degree type 1 for a little while. Typically a second degree type 1 is temporary, it's not a sign of some underlying destruction or injury to the underlying tissue. It typically will go away. It may happen while the person is having an inferior MI, so that's certainly serious, but it doesn't necessarily mean it's permanent, okay? The only time where second degree type 1 becomes serious is if that pause makes it so slow that it becomes a truly bradycardic rhythm. But in and of itself, it's not a particularly serious rhythm. Okay, and most patients are asymptomatic. Okay. Okay. Okay, here is an example. Again, we start off, here's the first PRI. You can see it starts to get longer, even longer. Now there's a dropped beat. Now there's an orphan, okay? And then it sets up again, does it again. And in this particular case, you really have to look for that dropped beat because in this particular case, the orphan is merged with the T wave. But it's just like finding, you know, non-conductive PACs or PACs within the T wave. You're used to that. You can see, oh yeah, there it is, okay? It's not a defining characteristic because you'll see this sometimes with second degree type 2, so it's not definitive, but a good clue that you have a second degree type 1 is you have what's called grouped beatings. Here's a group, here's a group, here's a group, here's a group, here's a group. Okay, that's the way it looks. There is no rule that says these groups have to stay constant, although they are here. So for example, here in each group, we see 3 QRS complexes. And probably that will continue. But there's nothing that says it has to. There's nothing that says that second degree type 1 will be regularly irregular, that the pattern is perfect. Typically it does stay pretty constant, but it doesn't have to. Yeah, Cody.
You kind of answered my question, but is there always 3 QRSs?
No, it could be 2, it could be 8, it could be 20.
If it is the 2 or the 8, is it always 8 in each group?
No, it can vary. So again, it's not uncommon. No, I'm not gonna say that. It's not uncommon for it to stay the same, okay? But if it changes, your reaction should not be, oh, it can't be a second degree type 1 because it should stay the same. Because sometimes it doesn't. Okay. Okay, and here's what I mean by grouped beatings. Okay. Here's more group beatings. So here's an example. So here we have our group. Did I put anything on? Here we have our group. Here we have our group. Here we have our group. Here's an example. If you look, here's the group, and it's 1, 2, 3, 4, and here it's 1, 2, 3, 4, 5. Okay. So it doesn't have to be the same. Let's take a break. Okay, I want to have fresh minds for the next idea coming in. So 9:41. Let's let's come back at 9:55.
Or
You
no,
say
his-
hello.
Let's start.
You said this is Natalie? I said something like that. No, I just started
Bless you. Thank you.
Sorry.
Ready?
Yeah.
Ready? Ready?
Call me out, Cody.
Okay.
Or not Cody, come on. Sorry.
Are you ready?
Sorry.
Okay.
We're good.
This next bit, let me emphasize, the only reason that we're going to talk about something called conduction ratio is not because it really matters that much, except it gives us a way of talking about second degree type 1 and second degree type 2 blocks. That's all we're doing. It's a nice way to be able to talk about what we're seeing. So with second degree AV blocks, and this is true of both second degree type 1 and second degree type 2, which is our next one we're going to talk about, we refer to the conduction ratio, which compares the number of P's to QRS complexes in each group. Okay? So what I'm talking about is, first of all, we only talk about conduction ratios within a group. So you have to be able to, the first thing you have to be able to do is look at the ECG strip and say, well, what's the group? So in this particular case, the group, so this is a second degree type 1, and it begins with the first conducted P wave in the group. So here's an orphan. This is the first conducted P wave in this coming up group, and it goes to the non-conducted P. So that's our group right there. And I'm making an assumption that there's a non-conducted P here, and I understand that's an assumption, but I'm going to do it anyway. So I'm going to say this is the first conducted P, and here's the non-conducted P, so there's a group. So we have two groups here, and what we're going to do, it's really straightforward, this is a lot of fuss about nothing in a way, is both of these are what we refer to as, we count the number of P waves in each group, so 1, 2, 3, 4, and compare it to the number of QRS complexes in each group. So both of these groups have 4 P waves and 3 QRS complexes. So P waves come first, so we say this is 4-to-3 conduction. And again, its only importance really is that allows us to talk about, to describe what we're looking at. Okay, so that's 4-to-3 and that's 4-to-3. Okay, so Grace, first of all, who has the pointer, by the way?
It is here.
Okay, why don't you pass that over to Grace? Show us, find a group, define the group, and then tell us what the conduction ratio is.
Grouping in twos and groups, and it's a 3-to-2 ratio.
Perfect. Okay, so see, it's not rocket science, although it took a lot of smarts to figure that out. Okay, so 3-to-2. Okay, so again, here we have 5-to-4. So here's our group: 1, 2, 3, 4, 5. 1, 2, 3, 4, and this one. So this is, remember I said, oh, grouped beating, it doesn't have to stay the same. Well, talking about the conduction ratio allows us to talk about it. So in the bottom one, it's 5-to-4, because here's our group, 1, 2, 3, 4, 5, followed by 6-to-5, okay? So, again, it just allows us to say, oh yeah, it changes. It changes from 5-to-4 to 6-to-5. Okay. Now, with second degree type 1 AV block, sometimes there is a really long stretch before the dropped beat. In fact, we're really not entirely sure that this is the first one, right? Because we can't see what's ahead, but here we have a really long, we have 1, 2, 3, 4, 5, 6. So it's at least 6-to-5, but it actually could be considerably longer because we don't know what happens here. And sometimes there's a really short stretch before there's a drop beat. So second degree type 1 can be long groups, short groups, okay? Now, the shortest possible group beating with second degree type 1 is 2 to 1. And what that means, we now know, means that there are 2 p waves for each one. So there's the conductive one, the non-conductive one. So this is in fact second degree type 1, and it's gotten to the shortest possible group beating, okay, 2 to 1, okay? Pretty straightforward, okay. Now notice that when it gets to 2 to 1, one of our criterion for deciding on second degree type 1 disappears, because one of the criterion is that the PR interval gets longer, right? But when it's 2 to 1 in a group, there's nothing to compare this to because there's no PR interval that follows before the group starts up again. Does that make sense? So this is one time where the only time with the second degree type 1 where the PR interval doesn't get progressively longer, because we don't have enough PR intervals in a row within a group to compare, okay? It's still second degree type 1.
Okay.
Yep.
For the third degree block that we just did for the examples, there was a couple that the PRIs were like not varied, but everything was marched out. Are those examples of second degrees, or just something?
Yeah, they are, but it could be second degree type 2.
Okay.
Okay, so we'll get to that. We'll circle by the end.
Okay.
You'll
Just
look
wanna
at
make
it.
sure those ones aren't just like
I am not gonna leave no stone untouched or whatever. Okay, now, Cody, you get to answer this question because you asked it. How do we know? So this is a second degree type 1. How do we know for sure that this is actually not just a normal sinus rhythm with a non-conductive PAC? Do you remember what we said?
The piece, it's not premature.
Right. So if you march it out, if you were to march this one out, so that's the first reason. There's 2 reasons. Number 1, this P wave follows the P wave pattern. And the second one is the PR intervals. Okay, we can see the PR intervals getting longer and longer. Okay, so for example, here we have second degree type 1 and the P waves march out. And here we have a non-conductive PAC, and you can see it comes in prematurely. Okay, and also our second clue also is if you look at the PR intervals here, they're constant because it's just a normal sinus rhythm, and here they're getting longer. Okay, now you have everything you need to do the next handout, which is on page 41. And it's, again, 2 pages, 18 through 25. And, you know, at this point, you can identify the following. You can identify second degree type 1s, and that's really what this is about. It will definitely be second degree type 1s. But if you happen to see first degree or third degree AV block, you might as well identify that as well. You still won't be able to identify everything, because we're still... Who's got the pointer?
I have the pointer.
Okay, Cole, yours.
I just went to Chris.
Okay, pass it back. Doesn't matter, it's all the same to me. Okay, Chris, number 18, please.
Number 18 is, yes, it is a second degree AV block.
Second degree AV block, which one?
Type 1.
Type 1, yeah, okay. Okay, everybody happy with that?
Yeah.
Questions? Okay. 19, you can pass that along, I think, to Anne.
That is yes.
Okay. And I agree with you. How do you know for sure? Because if I just glance at it, I have to tell you, it looks to me like a normal sinus rhythm with a non-conductive PAC. How do you know it's not?
You look at the PR interval as they progressively get longer,
Okay.
and then the P waves do reach out evenly, and then it
perfect.
Yeah.
There's your answer. Yeah, the P waves, if this is a non-conductive PAC, it has to be premature, and it's not. And then the other thing is, of course, the PR intervals. Now, let me show you a trick that you'll find helpful. Is sometimes, in this particular case, it doesn't really apply, but I'm going to show it to you anyway. Sometimes there is a pretty dramatic difference between this and this, but sometimes, particularly if you are not able to start at the beginning of the group because it's off the page, it sometimes helps you to compare. You always want to compare the first in the group to the last in the group is a good way to think about it, okay? Well, here's the first in the group, here's the last in the group, and they're really close together. So instead of worrying about what's happening along here, you can simply go from here to here and say, oh yeah, considerably longer. So you might just find that, it's just a little trick. We'll talk more about it. Okay, next one, please.
This is an all science rhythm with a PAC.
Non-conductive PAC.
PAC.
Yeah, absolutely. Okay. So, questions? Everybody catch it?
Riley showed me
Okay. Well
that.
then.
Thanks for the credit, bro.
Okay, Riley, what about 21?
No, it's not.
Good. And why not? I agree with you.
It was because it looks like the PRI intervals are equal. or
Okay.
Constant, I guess
Yep.
is what we said.
Yep.
And then also also looks like PR to Rs or QRSs are also constant. But anyway, yeah.
Yeah, and do you have the pointer?
Yep.
Point to the P waves.
Here's P,
Uh-huh.
P, P.
Now,
Or that.
if you use that as the P waves, do they march out evenly?
I think they actually do. Or hold on, I don't know. Let me check. If you consider a P wave to be buried in the
Right.
tree, then yes.
Right, yes, and that's exactly what's happening, is there's a buried P wave. So another reason, this is not in fact, maybe the most important reason why this is not a second degree type 1 is it has 2 orphan P waves in a row, which we just don't see with second degree type 1, because one of them is the buried one, and then one of them is this, and then we have a conducted one, non-conducted, non-conducted, conducted, okay? Okay, next please.
No, what about second degree AV type
And what is it?
1? Normal science.
With what? Remember, step whatever the step is, you have to, from this point on, you have to measure those PR intervals.
For the PRI is long,
So what would that be?
first degree.
Yeah, so it's a normal sinus with a first degree AV block. Okay, so don't get tripped up. From this point on, get in the habit of measuring the PR intervals. Okay,
I got 23, and I think that is a second degree type 1.
excellent. Okay, next.
So this one was a third degree.
Excellent. Okay, the P's march out, the QRS's march out, and the PRIs vary. Perfect. Okay.
For this one, I said it was a second degree type 1.
Yeah, everybody catch this one? See it? Okay. Again, it's not particularly tricky other than the P's are, the non-conductive P's are buried in the T's. Other than that, it's pretty straightforward. Okay. We're almost there. Second degree type 2. Second degree type 2, the underlying mechanism is in a way a lot easier to understand. So if there's a second degree type 2 AV block in the AV node, what happens is the SA node, per usual, is just throwing out impulses, okay? They hit the AV node, and sometimes they are conducted through, and sometimes they are not. So it's kind of on or off. There's none of this progressively stretched out PR interval. If it blocks it, it blocks it. If it conducts through, it conducts through with a consistent PR interval, okay? So the PR intervals are going to be consistent, and there will always be orphan Ps, Okay, so it's either on or off. Okay? And we'll look at examples. So, second degree AV block type 2 or Mobitz 2 is what you get is, again, it's either on or off. In this particular case, a whole bunch of them are going to go through. The PR intervals are exactly the same, and all of a sudden there's a non-conducted one. So that's second degree type 2. How do you know it's second degree type 2? It's because the PR intervals are constant. If they got wider, 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 it would be second degree type 1. Okay? So, second degree type 2 is kind of the trickster because it can present in a bunch of different ways, and we're going to see that in a few moments. The P's, as always, are regular. We have a regular rhythm of sinus P waves happening in the atria. The QRSs can be regular or irregular, and we're going to see examples of both. Okay? The rate just depends. There are always orphan P's with second degree type 2. There are always non-conducted P's, which means that there will always be more P's than QRSs. The PR, this is important, the PR interval can be normal, meaning 3 to 5 small boxes, or it can be prolonged as though it were a first degree AV block. So it can be either one, but the important thing is there's no variation like there is with either third degree AV block or second degree type 1. It's constant all the way through. And the QRS can be narrow or wide based on the level of the block. Okay, now, etiology's there. Here's the thing about second degree type 2. When you look at it, it may look very similar to a second degree type 1, but when you're thinking about the underlying cause, the pathology of what's happening, it's always considered far more serious than type 1. Remember, we said in many cases type 1 is just a benign happening. It just kind of happens sometimes for conditioned athletes or kids or whatever. It can also happen because of MIs and so forth. But second degree type 1 is almost always temporary, and it's rarely, even if there's an MI happening, it rarely means that there's some infarction to that particular part of the heart. Whereas second degree type 2 is much more likely to have underlying structural heart disease. It's much more likely to be permanent. It's much more likely to be associated with true bradycardia, in which case you'll have to treat the person. And it also has the danger of that block becoming permanent, so and moving into a third degree. So damage is more likely below the level of the AV node, and that can lead to, that can cause a form of an IVCD leading to a wide QRS. Now, this is where second degree type 2 gets tricky. Here is an example of a second degree type 2, okay? You can see the PR intervals, we have some orphan P waves. The P's are going to march out, the PR intervals are regular, but there's only one orphan at a time. Okay, there's one, there's the other, and presumably, so this one actually looks an awful lot like a second degree type 1. It's just that the PR intervals don't increase. However, sometimes with second degree type 2, there are multiple orphan Ps. Okay? And not surprisingly, this is considered far more serious. Okay? Some people will call this, and this is not a name that I'm requiring you to learn, but some people simply call this high degree AV block, when it's a second degree type 2 with multiple non-conducted Ps. I'm not requiring you to learn the name. You can just call that a second degree type 2 AV block or Mobitz 2. But I do want you to know when you see those multiple non-conducted Ps with a second degree type 2, that it's more serious. That clinically is important for you to know. So like I say, second degree type 2 tends to be kind of a trickster because, you know, if I say to you, well, are the QRS complexes regular? Yeah, sometimes. Are they irregular? Yeah, sometimes. Is there one non-conductive P in a row? Yeah, sometimes. Are there multiple non-conductive P's in a row? Yeah, sometimes. It tends to vary. So here's an example. And again, but the one characteristic that's the same is the PR interval stays constant throughout. Here's another example. So, and, okay. Okay, now, quick, you know, we said grouped beating tends to be a characteristic of second degree type 1, but it also happens sometimes with second degree type 2. So Anne, if you glance quickly at this, you might be tempted to say that's a second degree type 1 because there's a single orphan P and there's group beatings. How do we know that this is not a second degree type 1?
The PR intervals are all.
Right, right. So if you get, I hope you get a whole lot more from this class than this, but if you get nothing else, the PR interval has now, measuring the PR intervals has now become really important. Okay? Okay, again, second degree type 2 with multiple non-conductive P's can be more dangerous. Sometimes it's called advanced second degree or high degree block. You don't need to learn those terms. You know, there was one year where I did sort of make sure that people learn those terms, and it drove everybody nuts and wasn't worth the brain effort it took to learn not a hugely important name. But what I do want you to know, if you have a patient with second degree type 2, which is not a common, it's not very common by the way, but if they have multiple non-conductive P's, that is definitely considered more serious than with single ones. And again, we said buried P waves tend to happen with third degree, but sometimes the buried P's also happen. We've seen this one a couple times with second degree type 2, so you have to go looking for them. Okay, 2 is the answer. Okay, let's go to the next handout, which is the second degree type 2. So example 26 through 34. And at this point, you should be able to identify if there's first degree AV block, you should be able to identify if there's second degree type 1, second degree type 2, or third degree.
These ones I definitely struggled with, so I'm going to start with your ABCD at the top. So there will be orphan P waves. Sometimes there are several, sometimes there's one. So I'm seeing orphan P's.
Okay.
The P waves march out evenly. That is, they do. QRSs, that's what I'm confused about, is that they do sometimes?
Yes. And sometimes they don't. So what all that means, so Cody, here's the deal, is with third degree AV block, the QRS complexes always march out even. Okay. So if you have one where they don't, then you can push third degree off the table.
Okay, cool. I see that.
With second degree type 1, with one exception that we're going to talk about next, they almost always march out unevenly. So most of the time, if they're even, you'll push second degree. You can push second degree type 1 off the table. The problem with second degree type 2, it's not a defining characteristic, so you just pass through that. Okay.
So passing through that, PRIs are all the same.
Uh-huh.
So which is, yes, they are all the same. So this is a second degree type 2.
Yes. Okay, now, you're not off the hook quite yet, okay?
All right.
So, but, because this is the crux of it, okay?
Yes.
So, why do you think, this is, first of all, this is a second degree type 2,
Okay.
okay? When you look at it, why is it not a second degree type 1?
So second degree type 1, the PRIs get longer and longer.
Well, that's true, but more to the point, how many orphan P's are there between the
Well,
QRs?
there's multiple.
Yeah, so it can't be second degree type 1, okay? However, I look at it and I think, well, there's orphan P's, the P's march out, the QRS's march out. Oh, I think this is going to be a third degree. Why is this not a third degree?
Third degrees, let's see. QRS is March, even. Oh, all the PRIs are the same. On
Correct.
Third degrees.
That's
Very-
it, that's it. If you kind of follow, at the very end of this lecture, although we might not go through it today, there's like a strategy. You do this when you have AV blocks. So if you're struggling with it, it really, I find that, not that you have to, there's multiple strategies. So if you want to use my strategy, it's helpful to go through it at the same time. And then when you get to the end, say, well, okay, I got there, but why isn't it this? Why isn't it that? And you'll get it real quick.
Thank you.
Okay. Okay, 27.
So 27 is a second degree AV block type 2.
Show me where the P's are.
Here, here.
I agree with that. Now show me where second degree type 2 always has extra P's, always has more P's than QRS, has orphan
Oh,
P's.
sorry, I missed that part.
Okay,
No, I forgot there always is orphan P waves, never mind.
okay, so what is it?
This is,
So there's no orphan
so it's
P's
just a null sinus
rhythm,
rhythm.
but you've measured the PRIs, I'm sure. So what does that make it? It is a normal sinus rhythm, but actually belongs in the AV block lecture. What's the PR interval? Is it normal or?
It's more than 5 boxes.
Okay, so what does that make
It's
it?
a first degree.
Yeah, so it's a normal sinus for the first degree AV block. Okay, there you go. Okay, Anne, I think you're next, number 28.
Okay, that is a, second degree type 2.
Okay, and tell us so let's go through it. First of all, why is this not a second degree type 1?
There are extra.
There's extra orphans, is that, yeah, so there's 2 orphans in a row. Not so much here, but at least at one place. So that means it can't be a second degree type 1. Why is it not a first degree AV block?
The conducted ones are regular. They're all, the PR intervals are all the same.
Well, they are a first degree AV block.
Oh, sorry, but for type, second.
No, I'm
degree
saying
type
first
1.
degree AV block.
Oh. Can you repeat what the question was?
Okay. I'm just kind of going through all our AV blocks, okay? So, first of all, your answer is correct. It is a second degree type 2. And your second answer is correct. The reason that it's not a second degree type 1 is because we have multiple orphans in a row. Now I'm saying, well, wait a minute, one of our other AV blocks is first degree AV block. Just a plain old first degree AV block. Why is this not a first degree AV block?
The first degree AV block would have just longer PR
Okay,
intervals,
prolonged
and
PR.
then there would these P waves march out evenly, and there are extra ones.
They're orphans, okay? So remember, first degree AV block, P, QRS, P, QRS, P, QRS, just like a normal sinus. It just has a prolonged PR interval. Okay, now, why is it not a third degree AV block?
Because it's not random. The third degree,
It's
I
true.
think of it as like the QRSs are random from the
Okay.
Ps.
I agree with you. I agree with you. Total disconnection. And more to the point, that's a good answer. More to the point, it's not a third degree AV block because the PR intervals when they happen, they're constant. Never happens with third degree. And also, the R to Rs march out with a third degree AV block, which they do not here. Okay, good job. Okay, yes, Cody.
Why wouldn't you call this, or how can you rule this out of not calling those just sinus pauses or blocks?
Because then what you're gonna have to, then I'm gonna say, well, what's this? There's never, sinus pauses or blocks
Oh, yeah, that's
never
right. No
start,
kidding,
yeah,
That's right.
yeah. But really good question, okay? That's what this stuff is not easy because you have to keep all these details straight. Okay, number 29, what you got? I think it's Spencer.
Second degree AV block type 1.
Good. And why is it not a second degree type 2?
It is not a second degree type 2 because the PRI intervals, excuse me, the PRIs get progressively longer.
Brilliant. Okay, perfect. Okay? So, next one, please, Ryan.
Yes. This is a second degree type 2.
Excellent. Okay, questions about this one? Okay. Why isn't it a third degree AV block? The P's march out, R to R's march out.
Why isn't it a third? you
Yeah,
said?
why isn't it a third?
So forgive me, I haven't quite memorized all of that.
That's okay.
Let's see. So the PRIs are, let's see, which one am I on? I'm on, sorry. The PRIs are there.
Perfect. Okay. Okay, 31, please. Koa.
No, it's not second degree type 2.
And what is it?
It's a third degree block.
Okay.
Yeah.
Yeah.
third degree block.
P's march out, QRS's march out, and the PR intervals vary. Good job. Okay, number 32. Yes, Cody, please.
On that last one.
Yep.
I thought it was a second degree type 1 because the PRIs keep growing.
There's no drop beat though.
So,
Do we have to see it within 6
first of all, you're not the first person to ask that question about this particular one, okay? Let's look at this one. This one really throws people, okay?
Yeah.
So here's 20, I'm gonna show 29 as an example of a much easier strip, okay? This is a second degree type 1. Here's the group, right? So this one gets longer, gets longer, gets longer. Notice that when we're comparing the PR intervals, the progressively longer one, we're comparing it within a group, okay? So we don't compare this one to that one, we compare this one to that one, to that one, to that one. You see what I'm saying? So if we look here, to be honest, there really aren't groups. Because if we say, okay, if you march out the PR interval, here's a non-conducted P. If this was second degree type 1, this would have to be a conducted P. And then the next one happens here, right? There is a P wave buried in this, okay? So that means this would have to be the group, because we have a conducted to a, you see what I'm saying? Does that make any sense?
Yeah.
So the group is here, in which case this one isn't in the same group. I mean, the truth is I'm creating groups where they don't exist, which is why it's sort of weird. So again, you have to, before you compare, you have to find your group. And our groups are defined by the first conducted to the non-conducted. So if this was a true group, here would be the first conducted, here would be the non-conducted. There's our group. So you don't compare this one to that one,
Gotcha.
okay?
So it's third degrees?
It's a third degree AV block. What makes this one really hard is it just happens, and really it's just coincidental, because there really is no conducted P wave. This isn't part of a group because this one doesn't conduct. But it just happens that the way the P waves and the QRSs fall is that the PR intervals are getting wider across the strip, but not within the groups, because there really are no groups. Okay? Okay. If you see this as third degree, just stay with it, okay? Don't question it. If you saw it as third degree, that's exactly right. I don't want to throw you off. Okay? And if you want to talk about this one more, let's do it at the end of class, just because I want to move ahead. This one will come up again, I'm sure. Okay, 32.
So it was a second degree type 2?
Yep, and can you show us the P's, please?
I don't have the pointer.
Hmm?
I don't have the pointer.
Who's got the pointer?
We went left-handed too.
I know. 32, yeah.
It's a half.
Orphan P wave, orphan P wave.
Excellent, there you go.
Normal PI.
Yep, good. Okay, 33.
So, this one and the last one was a secondary type 1,
Mhm.
but I'm having trouble understanding this one because it looks like they're in groups of 2s. It's grouping of 2 with a 3
Mhm.
to 2 ratio. So it's a type, it's a,
Second degree type 1, yes.
but, so this one would be, this is where I'm getting tripped up, because this is the one that doesn't
Conduct, right,
And that's just an orphan then?
yes.
Well, how do you tell when they're orphans or just, that's not the end of the cycle? Because the PR does get bigger.
Well, because there's another P. An orphan means there's no QRS. If this was conducted, there'd be a QRS somewhere.
Right.
Right.
So because even in like right here you have an orphan,
Mm-hmm.
right? And you have an orphan right here,
Mm-hmm.
and then you have the start of one, and you have the start of one. So why is this not a type 2, a second degree type 2?
Because the PR, it would be a type 2 if the PR intervals were the same.
Oh my gosh.
Yeah, I
Right,
know.
we're good.
There's
We're
so
good.
many.
We're
There's
good. I
there's
was
so
mixing
many.
those up.
There's so many details to keep straight. So I don't expect you all, we're going to finish up this class. Hopefully we'll have a little time to practice. Then you're going to go home and you're going to work in Huff and you're going to do it and things will start to come clear. And then you'll come back next week and all we're going to do is practice everything but lots of AV blocks. So the fact that you all don't quite have it now, well, duh, you haven't had a chance to work on it. Okay, so don't worry about it. Sounds to me like you're all doing like in the place where you should be. Okay, 34.
First degree.
Great. Okay, we'll leave it at that. Okay, we have one more thing to go through and then some practice and then we'll call it a day. So comparing type 1 and type 2 second degree AV block. This is just a repeat, but it's kind of an important one. Not just a matter of differing ECG characteristic. I've already said this, but it's important. The underlying mechanisms are different. Second degree type 1 usually originates from within the AV node, frequently benign. Okay, as clinicians, that's important for you to know. Rarely progresses to complete heart block, usually temporary, goes away. Second degree type 2, by contrast, usually originates below the AV node, just outside of the AV node. It frequently results from conduction system disease, may progress to complete heart block, usually permanent. So if you want to summarize those two slides, second degree type 1, rarely serious. Second degree type 2, nearly always serious. Okay? Now, we depend on the PRIs to help distinguish second degree type 1 from second degree type 2. And the only reason I'm using Grace as an example here is because she just went, because everybody's made the same example. The same sort of, I don't want to say mistake, it's just the same learning process, is you look at something and you say, well, how do I know if this is second degree type 1 or second degree type 2? Look at the PR intervals. If they're progressively expanding within the group, it's second degree type 1. If they're all the same, all across the strip, within the group, whatever, then it's second degree type 2. So we depend on the PRIs to distinguish it. With second degree, now this one looks kind of similar to this one. The conduction ratios aren't exactly the same, but it looks really similar. And if I say to you the top one, in fact I did because we had this one, and I said, well, why wasn't this a second degree type 1? And the answer is because the PR intervals don't vary. Why isn't this a second degree type 2? It's because the PR intervals do vary. They get progressively longer. However, unfortunately for us, this is just to make our life difficult, is there is one type. So again, most of the time, second degree type 1, the PR intervals vary. But there is one second degree type 1 where the PR intervals are all equal. And that's second degree type 1 with a 2-to-1 conduction ratio. We've already looked at this, and until I introduced second degree type 2, this probably seemed, oh, this is easy, this is really straightforward. It's just when we keep accumulating stuff, it gets complicated. This, first of all, this is a second degree type 1 AV block. If you're able to look inside that person's heart to see what's causing it, it is a second degree type 1 AV block. But there's no way to talk about PR intervals that progress because there's only a single PR interval within each group. So they don't get a chance to progress because it keeps dropping too fast. Okay, there's no chance for this PR interval to progress because it creates an orphan, and remember then it resets itself. Every time there's a non-conducted P with second degree type 1, it resets and it goes back to where it began. However, second degree type 2 can also have a 2-to-1 conduction ratio, unfortunately. Life would be easier in this class without that. This is a second degree type 2 AV block. If you could look inside this person's heart, it would be second degree type 2. And it looks precisely the same, okay? Because there's only a single PR interval at a time. So, what that means is because both type 1 and type 2 with 2-to-1 conduction looks alike, identification is difficult. It's not impossible, but for us, we're not going to worry about it. We're just going to call it difficult. So in this class, we will call it second degree AV block 2-to-1 conduction, meaning it's an umbrella term. It means it's either second degree type 1 or second degree type 2, but in this one situation with 2-to-1 conduction, it's a special case. We can't tell whether it's type 1 or type 2. So this is how, if you look here, we have our 2-to-1 conduction. We have, here's our group, 2 P's for every single QRS. That's 2-to-1 conduction. There's no way from this ECG, or at least none that we're going to learn, that we can tell second degree type 1 from second degree type 2. So in this case, I don't want you to call it second degree type 1. I don't want you to call it second degree type 2. I want you to call it second degree AV block 2-to-1 conduction, understanding it's an umbrella term. Can be either type 1 or type 2, we just can't tell. Okay, our last handout, and we're going to do it together. Well, not really our last handout, but our last handout for now. Okay. So, who's next?
Unfortunately, it was Martin.
Who's next? How come you have to keep starting?
I don't know.
I don't know. Okay. So let's just kind of work through this together. So first of all, let's start off with our 5-step process.
Okay.
If you march out the P's, are they equal?
Yes.
Okay. And if you march out the QRS complexes, are they equal?
Yes, they are.
Okay, and even though we haven't been emphasizing this because we're doing the 5-step process, what is the rate, meaning the ventricular rate, about?
Brady.
Rate. Brady what? Like how fast is Brady?
230.
Yeah, so very slow. Okay, so now we want to look at the P waves.
Yeah.
Okay, and are they upright all the way across?
Yep.
Okay, and we've already said they march out, so we know they're sinus P waves. And now the all-important question, are there more P's than QRS?
There is.
Okay, so we have orphan P's, okay? So we know it's going to be a an AV block of, say it again?
Second degree AV block with a 2-to-1.
Okay, there you go, okay? This is a second degree AV block 2-to-1 conduction. And what do we mean? What does that mean? It could be either what or what. It's an umbrella term for what?
Type 1 or type 2.
Type 2, okay? Everybody see it? Okay. Okay, Chris, you're next. What you got? Number 36.
Alright, so QRSs don't work out evenly. You've got, PUAs don't march out evenly either.
They don't? I think they do.
Just getting it right, they do march out evenly.
It's that, yeah, I know, you looked at it and it looked like one was longer because there's no QRS in the middle. I know that
Yeah.
trick.
Well, in that case. PRIs are not the same.
Okay?
So.
Somebody help them out. What is this?
That's type.
Okay, we have one vote for second degree type 2. What else?
Type 1.
Type 1. So why is it type 1?
The PRI interval is, it gets longer and then it has the drop beat, it's a 3-to-2 conduction.
Okay. So one thing to remember is, again, when you're looking at when you think you have an AV block, and we think we do because there's orphan Ps, right? So very good chance that so if you then look at the PR interval, they're not constant. And there's only 2 AV blocks where the PR intervals vary. What are they? Third degree, and this type, which is what? Second degree type 1. So if you have varying PR intervals, can't be a second degree type 2, and it can't be a first degree, so it's got to be either third degree or second degree type 1, okay? Because the PR intervals vary. Now this can't be third degree. Why can't this be third degree?
The QRSs aren't even.
QRSs are not even. Okay, so all that's left is second degree type 1. Okay. Okay. Next, please, Ann.
I do believe that is another second degree AV block with the 2-to-1 conduction.
Okay, and can you get the pointer and show us where the P waves? Because this one is not tricky, except people sometimes get mixed up about where the P waves are.
Where's the pointer?
Who's hogging the pointer, bro?
Okay.
That drop,
Man.
hands like feet.
And so there's P waves hidden. And there.
Okay.
There's one. There's one.
Correct.
There's one.
Correct. Okay? Yeah, so this is that 2-to-1 conduction. Okay. Number 38, please.
I believe this is a second degree AV block type
Type
2.
Good. Okay?
Because the PARI is not
Okay.
constant.
Okay. Excellent. And multiple orphan Ps. Good. Okay, 39, please.
Okay, so I immediately think it is not a 2-to-1, because the QRSs don't march out evenly, so that kind of.
Oh, that's, yeah, very smart, okay.
So that kind of popped out first.
Okay.
Then I gotta figure out what it is.
Right, but that was, yeah, that was smart, okay.
Let's see, PRIs are constant.
Okay,
Let's see, the P waves, look like they march out evenly.
good.
So let's see. Second degree AV type 2.
Good, good. And notice that this one is a little bit tricky, because if this wasn't here, like if this was cut out, it actually would be second degree, 2-to-1 conduction. This is the one that screws it up. Yeah, good job, really good job. Okay, whoever's next?
I think it's second degree, 2-to-1 conduction.
Excellent. Yeah, it looks really squirrely until you really march out. If you just really march out those P waves, you can see the 2-to-1 conduction. Okay, next one, please.
second degree type 2.
Okay, excellent. And where are the P's? Can you point to them, please?
I don't have.
Somebody get Andrew the. Okay,
41. Yeah.
okay. I think you're missing one, because if those are the only ones that are there, they don't march out evenly.
They're in the trees. They're in the trees.
Yeah. So, and maybe you pointed to it. It looked to me like you were skipping it over, but there you go.
I'll
Okay.
be honest, I skipped it.
I thought you did, actually. So, yeah. Okay, Grace, what about this one?
Kate, okay. So, my first question, is this a P?
What's your inclination?
Yes.
Yes, I agree with you.
Is this just a inverted T?
Yeah, it's really, you know what, it's really hard to know precisely what's happening, because the P, and it is a P because it marches out, right? And is pretty much the same shape. So something funny is happening here. It's really hard to say what's happening to the T wave between all the ST elevation and this P wave. I don't know if it's inverted or just screwed up, but it is a P wave.
Okay, so second degree type 2.
Okay, and my guess is you went through the whole process and you came up with the fact that the PR intervals are constant, and that was great. Before you say second degree type 2, because I suspect you did everything right, then double check, is this that special case where it's two, of course it's not a special case, otherwise I wouldn't be making such a fuss about it. So it's 2-to-1 conduction, right? And I'm guessing that you did everything right in figuring it out. Now you just need to add that little extra thing, is it 2-to-1 conduction? So.
And so it's a 2-to-1 if it has 2 P's and 1 QRS.
Correct, in a group.
And it copies on copies.
And it copies and copies, exactly. Okay, what you got?
I said third degree.
Good. That's all we have to say. Anybody questions on this one? Just third degree. Okay, now, so we're not quite done. We're going to go a little bit longer. We'll probably go about another 10 minutes. Your job this week, so just to be, so you're really clear about what's happening in this class, is next week we're going to spend the whole class period practicing. And we will be doing a whole lot of practicing of AV blocks, but everything else as well. Because the following week is the final. And we'll also, you can find the study guide for the final online, but next week we will go through the study guide. If you haven't already, be sure to pick up the ECG strips for the final. I'll also have them next week. Okay? Now, again, we're not done. We still have a few more slides. Your job this week is, I hope this is obvious. If you go through the whole week and don't practice AV blocks and then come in next week and haven't practiced, you're going to have trouble. So you really need to do, this is all about just practicing and practicing and practicing until all these pesky little details start feeling more natural, okay? Now, there is one book problem, so pay attention to this because I know you're going to be practicing in Huff.
Yes.
Huff calls 2-to-1 conduction, second degree 2-to-1 conduction, calls all of it second degree type 2. What you'll see is second degree type 2 clinical correlation. It makes no sense to me, in particular because although we're not going to learn it, there are actually a few little clues when you look at the ECG, whether it's second degree type 1 or type 2. So I can look at some of those and say, no, that's not a second degree type 2. I think that's more likely to be a second degree type 1. So be aware of that. I don't want you to use that term. I'm going to on the final, of course there will be second degree AV blocks 2-to-1 conduction. Of course. And so that's what I want you to say. So just watch out there. Okay? That's one thing. Oh, I'm not doing this next bit. There's a couple slides about how to tell them apart, but I don't care about that. Let's see, what else? Okay. I'm not going to go through this now, but I do have it sort of a strategy laid out, sort of a more concise strategy laid out on how to approach these AV blocks. So in the weekly to-do list, I've linked to these slides specifically. I've also written it out, on a Word document even more succinctly. So if that's useful for you, use it. If you find that it just confuses the issue for it, no problem. There's no requirement to use it. Yeah.
So is this, the work you did for us, is it basically just kind of narrowing down
Putting
the
it all
difference?
together.
Yeah, narrowing down the differences?
Yeah, and also coming up with, what it really comes down to, like I've really emphasized the 5-step process. And what it really comes down to in the 5-step process is once you realize there are orphan Ps, then you should start thinking AV blocks. So it's at that point, if you want to use this process, you say, okay, I've got orphan Ps. That means it could be this, or this.
Okay. Thank you.
Okay. And again, no requirement. I'm not going to test you on that or anything. And I think I'll just call that good for today. So, so see you.